Hi, this is Ike Ahmed from the University of Toronto. My pleasure to speak on a topic that's become more exciting for me, the visual field. There's some exciting developments that we're seeing with new technology in perimetry, and it's my pleasure to speak about the technology that we're going to speak about, which is Fundus Perimeter using the center view compass. This is a talk that I built based on our current experiences, and we actually have some updates that I'd like to share with you during this presentation. My disclosures are listed here below, and I do want to point out that I do serve as a consultant for Centerview and have been working with the company now for over a year and a half, helping to help develop some of these technologies, and have had experience now with these devices for that time period. So, perimetry and glaucoma, what I want to cover a couple of things. Our visual field is still relevant in glaucoma. We hear a lot about OCT and imaging of the nerve head and RNFL and macula. What roles are there for visual fields? One of the reasons why we question that very point is because of the concerns we have for reliability and retest reliability and repeatability, and the differences and difficulties with variability and assessment of progression. And can new technologies like the compass potentially enhance and improve reliability that can actually enhance the confidence of our ability to monitor for progression? And by doing so, can it help us to make treatment decisions earlier and wiser and more effectively? And those are the kind of questions that I want to consider here as we look at perimetry, which has been really a mainstay of glaucoma screening and diagnosis and progression management over the years. Of course, when we think about glaucoma, we know about the structure and function relationship, the optic neuropathy, RNFL loss, and macular loss that's associated with visual field loss. Of course, typically in most patients, structure changes often occur prior to functional changes, although not always evident on our imaging devices. And so we have to, of course, always consider the relationship between these two. We still have an important role in examining the optic nerve head and the peripapillary RNFL, both clinically as well as documentation-wise. And one of the things I always highlight on thinking about structural function is we've seen rapid changes in OCT technology and imaging technologies. One generation is difficult compared to the next generation, and I always find it very helpful to have old optic nerve head photos of patients that I can assess and follow. Visual fields certainly have a role, and I think that many of us look at visual fields having a particular role as the disease has become more advanced, where we have visual field defects. So I think the interplay between structure and function is very evident and very important to recognize. When it comes to staging of disease, I think many of us still rely on the visual field to classify the patient's disease state, whether it's mild, whether it's moderate, or whether it's advanced. And using either mean deviation, as you see on this slide here, based on the number of decibels here, and mean deviation loss, is one way to look and classify the degree of disease, as well as the potential for fixation-threatening defects. Structural assessment is also helpful to classify, although certainly in my opinion, there's a significant amount of variability, of course, based on the optic nerve anatomy and size. And so I find it not as reliable to determine severity. And if we really think about glaucoma and treatment of glaucoma, the goal of treatment of glaucoma is preservation of vision. And that's why I think the visual field really still is really the mainstay in terms of determining a patient's visual field and disease severity and their risk of losing vision or going blind. Progression analysis is absolutely key in terms of monitoring disease, and for many of us, perhaps it's even more important than actually making the diagnosis, but it's actually monitoring the patient to see whether they're stable. We have better tools than ever, looking at serial topographical changes, as seen on HRT on the left side of the screen, as well as now fairly robust progression analysis, as seen on the right side, that can use both trend and event analysis to determine progression. One of the challenges of visual field analysis is looking at the number of visual fields required to actually adequately assess for progression. And this paper that was published by Chauhan and others, I think really kind of highlights the amount of time required to detect progression. As an example, if a patient has 3 examinations per year, which is a fairly frequent examination period, to detect even a 1 decibel loss of mean deviation, which is actually a quite fairly rapid loss, with moderate variability, would require at least 3 years for that detection to be adequately detected, considering the variability and the progression rate. For many of us, that's a seemingly unacceptable long period of time to detect for progression. And you can see part of the reason for this is the variability. And of course, somebody who has a highly variable visual field will take much longer. We're seeing studies to show that the reduction in variability allows us to detect disease earlier. And this particular study showed that a 30 to 60% reduction in variability in visual field assessment resulted in detection of visual field deterioration 1 year earlier than current methods. And so, this is just one example to say that if we can actually reduce variability, we can detect disease earlier and treat the patient more aggressively and hopefully preserve their vision. So how do we reduce variability and improve our confidence in the ability to make a diagnosis, and of course to make a diagnosis of progression? This is where technology has moved forward. Now, the COMPASS automated fundus perimetry is built on a couple of important principles. This is a scanning ophthalmoscope that's associated and attached with this automated perimetry. This allows for quote-unquote real-time retinal tracking using the scanning ophthalmoscopy image of the retina and allowing one to then track the retina by projecting the parametric points to be assessed, specific retinal loci. This also provides a very nice confocal disc and fundus photography for structural documentation, and this does not require the use of trial lenses and refractive lenses to treat the patient's refraction for the visual field testing, which is a nice way to do this. In what's free testing makes it easier and hopefully more reliable and not relying on those tools. The COMPASS device, you can see, is built differently than we see with the classic bowl type perimeters because of the projection confocal nature of the system here. It's a fairly sleek system. This is a very automated system. Century is a company that's built on automation and ease of use, and certainly this is no exception in terms of how the workflow is built around the patient. This is an example showing standard automated perimetry where during the examination, the stimuli may hit different points based on the patient's fixation. And although there are ways to try to look for fixation, current devices do not adjust for fixation. And this is very familiar for those of us that have familiarity with microperimetry, where adjusting and tracking, of course, allows for a more robust and precise location. And of course, cooperation is a problem. Here's an example where we see fundus automated perimetry where the fixation losses and changes are actively compensated by the device itself. And that basically essentially recalculates the position placement before it's presented to the patient. This is also really excellent to allow for retest and follow-up testing that basically will then essentially test the same points that were tested at the previous examination to ensure for adequate determination of progression. This slide just shows the different types of fixations for different types of patients. You can see that the patient has a very stable fixation, has a very small radius and a small diameter of fixation changes. While on the right, you have a very unstable patient with a very wide-ranging eye movement and positional changes. The top graph, basically, the top part shows essentially a non-compensating visual field analyzer, where basically you can see how large that fixation degree is. While below, you see the COMPASS, where you see a very tight fixation range with a stable patient, but particularly this is really highlighted in the unstable patient on the right, where you see the difference, someone who's very unstable on a non-compensated device versus a retinal tracking device like the COMPASS, which really narrows down that range of variability, which is immensely helpful to really get a more reliable visual field. And so the ability to adjust for this is an important concept in terms of assessing glaucoma and assessing for progression. We also know, of course, that many of our glaucoma patients, particularly those with more advanced glaucoma, have eccentric fixation. And we know, of course, that because of that and because of the visual field loss, that these patients have worse visual acuity. And the ability to, compensate for the fixation losses and eccentric fixation really, again, enhances the ability for us to assess adequately. This device also allows us to assess the patient's fixation as well. And this can also potentially be used to assess for visual function as well in these patients, again, who have these issues coexistent with their disease. The confocal ophthalmoscope imaging of the device allows for infrared and red-free images, as well as a nice color image, which can be helpful to look again for structural changes, particularly RNFL defects and cupping, in a very robust and a very real-time color, true color picture with white light. The confocal image, of course, really provides the highest quality vision. It reduces the defocus part of a non-corrected or non-confocal image, and we see the images here. It's good examples of what this device delivers. So it's a nice way to be able to have that structural assessment. Certainly, OCT is still, the gold standard when it comes to RNFL analysis, and as well as optic nerve head and macular analysis at a deeper level. But this really gives us a true physiologic picture of the optic nerve and the posterior pole. Let's just run through the printout of a classic compass printout here, and you can see how the printout is laid out with various parameters. The very top basically essentially shows our patient examination information. The reliability indices include basically blind spot, false negatives, and false positives, which are essentially the reliability indices on this device. As you can see here, there's no fixation report because this device essentially compensates for fixation, which is tracked, as we'll talk about. Pupil size is also documented as well, which is also going to be an important variable in terms of reliability. At the very top, you see that we have the mean deviation and the pattern deviation reported as per standard protocol. And then we have our disc photo, which is seen in the top right, which is a magnified view of the optic nerve and peripapillary area. And then we have a red-free retinal image here, which is shown with overlying retinal sensitivity values for each retinal loci. And remember, this is basically the anatomical representation of the patient's visual field and where the retinal sensitivities lie. And in red, the red, orange, and green basically highlight the patient's range in terms of being either abnormal, borderline, or normal compared to an age-matched control. An interesting way to present some of the hemifield data is using cluster mean deviations, is basically show the difference between different hemifield clusters between the superior and inferior fields. And we know, of course, that the differentiation between superior and inferior clusters or hemifields can be an important distinction in glaucoma, and can also potentially be used for progression analysis as well, as we'll see. The standard grayscale plot associated with the total deviation and pattern deviation plot are reported here next, which again are the classic tools that are used for the assessment of the visual field. And then we see the posterior pole color photo, a nice broad view of the posterior pole, which includes the macular area as well. Tracking performance is indicated on the bottom here, and you'll see essentially in blue, basically it says tracking the patient's fixation. The greater the degree distance over time essentially shows the patient's patient's movement. One has to remember, though, of course, that essentially this is a compensated test. So although there may be fixational movements, this is being tracked and monitored and compensated for. I look at this actually interesting enough to see what would have been like if we didn't track for it, and if the patient had a lot of variability and changes, then I would have probably guessed the patient would not have done as well in a non-compensated perimetry analyzer. And so the fixation area can be assessed, and this can essentially tell us the degree of eye movements over time. These are 4 different examples of patients with various amounts of cooperation and fixation losses. And on the left side, you see patients with fairly good fixation. On the right side, you see patients who have quite a large degree of fixation variability and movement. All 4 of these patients actually still performed fairly well and reliably on the compass. I think it's fair to say the patients on the right, in a non-tracked environment without retinal tracking, though, would have significant fixation losses and likely have a highly unreliable visual field. And this is kind of just an example. We know our patients vary considerably in terms of those that are able to fixate well and those that aren't, whether it's from cooperation or for other reasons. Let's just run through some examples looking at some of the printouts. This is just a printout of a patient's right eye, where you see the patient has on looking at the red-free image, one can see in red the retinal loci that are affected there, predominantly more so in the inferior hemifield than the superior hemifield, or I shouldn't say hemifield. I should say the retinal loci. And if you look at the visual field, you can see that the superior hemifield is affected more so because, of course, the inferior retinal loci have been shown here in red. And when we look at the OCT image of this patient here, we see a reduction of the patient's RNFL thickness, and this is particularly more marked inferiorly, which again correlates very well to the retinal loci reductions on the red-free image as well as the hemifield defect that's present here, arcuate defect on the superior hemifield. This patient did have a fair amount of tracking issues as far as the patient moving somewhat, but had still a very reliable and a very useful visual field that again correlates very nicely structure to function here. This example shows a classic Humphrey field analyzer printout along with an OCT and along with the compass printout of the same patient. And so here you can see the nice comparison here and the reasonable representation between all these devices, where as you see the OCT shows predominantly superior RNFL loss, and both the Humphrey and the compass both show a fairly similar inferior field defect, which is consistent with the structural abnormality. This patient you can see here has significant disease, but has repeatedly poor reliability indices. Very high fixational losses, you see 10 out of 19. And if you look at the bottom of the screen, you can see the tracking of this patient here, significant eye movement here as determined by the Humphrey field analyzer. When we now look at repeated fields, we see continual issues with the Humphrey field. And this patient, and now we look on the very right, we see a much more reliable field in a patient who had the compass, same patient here who had the compass. And although on the bottom right, you see the degree of fixation changes and movement of the eye here on the bottom, significant tracking movement here. Because of the compensation, we have a more reliable visual field. And we have a visual field which is actually fairly different than what we see on the Humphrey. The question is which one is the one that matches most correctly? Well, I think that the one that's compensated and the one that's more reliable is the one that's likely to be more accurate in this patient's diagnosis and looking at where the disease is. Hopefully, again, it will be helpful to assess for where they're progressing as well. Just more examples of showing patients who have significant fixation losses, but yet when put upon retinal tracking fundus automated perimetry, have a very reliable result. In this case, the visual field defect was somewhat similar to the Humphrey field analyzer, but again, I think we just have more confidence now. We're not guessing and saying, is that real or not? How big is this defect? What's happening? Are they changing? Are they progressing? Because we know we have a reliable visual field, which we really can count on. Another example where we had a patient, again, who had a lot of fixation losses, a visual field that was really very poor to understand with some of the central losses here, had glaucomatous optic neuropathy. And as we see on the compass here again, a very reliable visual field, which again shows a very refined, localized visual field defect, which again is going to be very helpful for us to be able to follow this patient in a more confident fashion. Just again, some more examples here showing a patient with significant movement and fixation losses as well. This patient has fairly reasonable optic nerve heads and RNFL. And on the compass here, although there was a lot of movement, as you see on the bottom left on the tracking here, we see again a fairly reliable visual field and a visual field that is relatively normal. But again, we can say this with confidence as opposed to again being uncertain. And again, not to belabor the point here, again just showing more visual fields with patients with fixation losses on the left. On the right, patient here who had again compensated visual fields. Now, this patient did still have a fair amount of false positives, which again we have to consider. This machine does not necessarily compensate for patients resulting in false positives or negatives. If the patient falls asleep, this device is not going to be able to do obviously the test. If the patient is trigger happy, that's also not going to be something, of course, that can be resolved by simply the device. It's obviously partly a training issue and an attention issue. So it's important to remember that there still are important patient cooperation points that have to be considered, of course, with perimetry. One of the new developments in the software with the Compass platform is the ability to have a follow-up and progression analysis testing. And this is continuing to progress and advance moving forward. Just like with the Humphrey Field Analyzer, we've seen the development of CETA testing strategies, which is a very efficient way to test. Compass has a proprietary ZEST formulation, essentially, that allows for a very efficient and well-performed and robust visual field analysis. Well, the Compass is also moving forward in terms of the progression analysis, and using a new follow-up testing method here allows essentially one to essentially test and retest at the same given point. And here's essentially a progression report here where we see baseline, last examination, and progression analysis, which essentially shows pointwise deviations from baseline and looking at linear regression for mean deviation progression. We also see cluster mean deviations that also can be shown to deviate from baseline as well. And again, it's absolutely critical for these patients to make sure we're testing the same point as we go from test to test to test. And if we're not confident we're testing the same retinal loci, and we're seeing a change at that retinal loci, we're sometimes uncertain whether it's really change or whether it's variability. And what do? We bring the patient back for more visual fields, and we kind of accumulate more and more visual fields over time before we finally make a diagnosis. Well, by that time, unfortunately, we've lost a few years potentially. Here you can see again, a patient's baseline, their follow-up examination. You see a pointwise deviation from baseline on their scatter plot, and then we see essentially the cluster deviation from baseline here that shows within each cluster where the changes are occurring for more localized deviation. And then the linear regression on mean deviation progression is shown below. We have now had some experience with the progression analysis on the COMPASS device. This patient here has both Humphrey and COMPASS visual fields. You can see the GPA printout here showing on the VFI index at least a couple of variability points here. And as we see on the follow-up examinations, we see some variability, and we see the nasal, superior and inferior nasal defects here that are of some concern. The COMPASS here progression, and again, we only have a couple of follow-up here, so really not enough to really give you a good example, but this is again still some early experience here. We see at least how the plot would be printed out in terms of how it would look like and what we expect to look like. Again, looking at some pointwise deviations on the scatter plot. We see on the cluster mean deviation, particularly on the inferior hemifield along the horizontal raphe, we see significant changes that are occurring, and we see the mean deviation progression here again on 2 points. Again, we wouldn't rely on of course only a couple of visual fields. This gives you a taste what it would look like, and I think we look forward to COMPASS, the development of COMPASS, to develop a really fine-tuned, robust statistical package, very much like we've seen on the HFA, which I think we've all been pretty impressed with as far as the GPA analysis. And combining retinal tracking and improved confidence and less variability with a robust progression analysis, I think, is really going to be the holy grail for early progression assessment. So the promise of real-time tracking perimetry, I think, is a very real one. I think we've already had some really early examples showing the potential benefit of the enhanced reliability. I've spoken a lot about the importance and the enhancements of the retest reliability in terms of assessing for progression. And I think, by reducing this variability, our real goal again is to ensure that we can detect progression earlier. I think this device has shown promise here, and we look forward to further developments with the device in terms of how it performs again in our practices, as well as over time in looking at progression analysis. I want to thank you for listening to this presentation, and again, happy to take some questions at any given time in the future.